In a pediatric patient presenting with signs of shock, what clinical parameters would indicate hypovolemic shock and what immediate interventions should be prioritized? Answer: hypovolemic shock is characterized by a significant loss of intravascular volume leading to inadequate tissue perfusion. Key clinical parameters include tachycardia, heart rate increases as the body attempts to compensate for decreased stroke volume; hypotension, low blood pressure may be present in late-stage shock; delayed capillary refill. A capillary refill time greater than 2 seconds indicates poor perfusion. Weak pulses. Peripheral pulses may be diminished due to reduced cardiac output. Immediate interventions should include fluid resuscitation. Administer isotonic crystalloid boluses at a rate of 20 ag and reassess frequently. This may be repeated based on the patient's response. Monitoring. Closely monitor vital signs and capillary refill during fluid administration to identify signs of fluid overload or pulmonary edema. Inotropic support. If the patient does not respond adequately to fluids, consider initiating inotropic agents like dopamine or epinephrine based on hemodynamic stability. A 6-year-old child with septic shock is being treated in the emergency department. What is the recommended approach to antibiotic therapy in this scenario, and why is it crucial to administer antibiotics promptly? Answer: in the case of septic shock, immediate broad-spectrum intravenous antibiotics should be administered as soon as possible, ideally within the first hour of recognizing shock. The recommended approach involves broad-spectrum coverage. Initiate with empiric therapy using a combination of antibiotics that cover likely pathogens, including gram-positive and gram-negative organisms. De-escalation. Once culture results are available, modify the antibiotic therapy based on sensitivity results. Prompt administration of antibiotics is crucial because time-sensitive treatment. Each hour of delayed antibiotic therapy in septic shock is associated with increased mortality rates. Early treatment can significantly improve outcomes by reducing the bacterial load and preventing the progression of sepsis. Inflammatory response. The inflammatory response associated with sepsis can lead to rapid deterioration in organ function. Timely antibiotics help mitigate this response. Mr. Johnson's 8-year-old daughter presents to the emergency room with signs of shock following a severe allergic reaction. After administering epinephrine, what additional treatments should be considered and what monitoring parameters are crucial for this patient? Answer: following the administration of epinephrine for anaphylactic shock, the following treatments and monitoring parameters are recommended. Additional medications: antihistamines, administer H and H blockers, e.g. diphenhydramine, ranitidine to manage allergic symptoms, corticosteroids. Consider IV corticosteroids, e.g. methylprednisolone, to reduce inflammation and prevent biphasic anaphylaxis. Monitoring parameters: vital signs, continuous monitoring of heart rate, blood pressure, respiratory rate, capillary refill time. Assess capillary refill to gauge peripheral perfusion. Oxygen saturation. Monitor pulse oximetry to ensure adequate oxygenation. Signs of fluid overload. Be vigilant for pulmonary edema, particularly if aggressive fluid resuscitation is necessary. Describe the characteristics and management strategies for distributive shock in a pediatric patient, specifically in cases of septic shock. Answer: distributive shock is characterized by an abnormal distribution of blood flow, often resulting in inadequate perfusion of tissues despite adequate or increased cardiac output. In septic shock, common characteristics include fever or hypothermia. Changes in body temperature can be indicative of infection. Vasodilation. Flushing of the skin may occur due to peripheral vasodilation. Tachycardia and hypotension. These are common signs as the body tries to maintain cardiac output in the face of vasodilation. Management strategies include fluid resuscitation. Administer IV fluids aggressively to restore intravascular volume, typically starting with crystalloids. Vasopressors. Initiate vasopressor therapy, e.g. norepinephrine, to counteract hypotension, especially if fluid resuscitation fails to stabilize blood pressure. Infection control. Administer broad-spectrum antibiotics promptly to address the underlying infection. Monitoring. Continuous hemodynamic monitoring using central venous pressure (CVP) and lactate levels to assess response to treatment and tissue perfusion. What are the indications for advanced hemodynamic monitoring in pediatric shock management, and what techniques are commonly employed? Answer: advanced hemodynamic monitoring is indicated when a pediatric patient with shock does not respond adequately to initial resuscitation efforts. It is essential for guiding further therapy and assessing hemodynamic status. Indications include persistent hypotension despite fluid resuscitation, need for inotropic or vasopressor support. Common techniques for advanced monitoring include Central venous pressure (CVP) monitoring provides insights into right atrial pressure and fluid status, helping to guide fluid resuscitation. Arterial line placement allows for continuous blood pressure monitoring and facilitates frequent blood gas analysis. Lactate measurement. Elevated lactate levels indicate tissue hypoperfusion, and monitoring trends can guide therapy. SCVO monitoring measures central venous oxygen saturation to assess the adequacy of systemic oxygen delivery and consumption. 4-year-old child presents with signs of cardiogenic shock after recent diagnosis of myocarditis. What are the key management strategies for this condition? Answer: management of cardiogenic shock in a pediatric patient with myocarditis should focus on stabilizing the patient while addressing the underlying cause. Key strategies include supportive care, maintain oxygenation and airway protection. Supplemental oxygen may be necessary. Fluid management. Careful fluid administration is critical. Avoid aggressive volume resuscitation to prevent fluid overload. Administer fluids cautiously based on clinical signs and hemodynamic monitoring. Inotropic support. Use inotropic agents such as dopamine or miranon to improve cardiac contractility and increase cardiac output. Monitoring. Continuous cardiac monitoring to assess rhythm and hemodynamics, including heart rate and blood pressure. Consultation. Early involvement of pediatric cardiology for further management, including potential advanced therapies such as mechanical circulatory support in severe cases. In the context of pediatric shock management, what role does lactate level monitoring play, and what lactate levels are considered indicative of tissue hypoperfusion? Answer: lactate level monitoring is a critical component of assessing tissue perfusion in pediatric shock management. Elevated lactate levels indicate anaerobic metabolism due to insufficient oxygen delivery to tissues. Key points include normal lactate levels. Typically, normal serum lactate levels are between 0.5 to 2 mol. Levels above this range suggest tissue hypoperfusion. Guiding resuscitation. Lactate levels can help assess the effectiveness of fluid resuscitation and guide further therapeutic interventions. A decrease in lactate levels post-resuscitation indicates improved tissue perfusion. Threshold for intervention. Lactate levels greater than 2 mol suggest a need for aggressive resuscitation efforts, and levels above 4 mol are particularly concerning and may necessitate advanced interventions. Monitoring lactate levels helps clinicians assess the severity of shock and response to treatment. A 10-year-old patient with tension pneumothorax is in critical condition. Describe the management steps you would take to address this obstructive shock. Answer: in cases of tension pneumothorax, immediate recognition and intervention are critical to prevent cardiovascular collapse. The management steps include immediate decompression. Perform needle decompression at the second intercostal space in the midclavicular line on the affected side. This allows trapped air to escape and relieves pressure on the thoracic structures. Follow-up chest tube placement. After decompression, arrange for the placement of a chest tube thoracostomy to facilitate continuous drainage of air or fluid. Supportive care. Provide supplemental oxygen and closely monitor vital signs for signs of respiratory distress or cardiovascular instability. Fluid resuscitation. Administer IV fluids cautiously to address any accompanying hypovolemic shock while monitoring for fluid overload. Prompt intervention is crucial in tension pneumothorax to restore adequate ventilation and prevent further deterioration. Explain the physiological changes that occurred during septic shock and how these changes affect the management of fluid resuscitation. Answer: in septic shock, a systemic inflammatory response leads to significant physiological changes. Vasodilation. Widespread vasodilation results in decreased systemic vascular resistance, contributing to hypotension. Increased capillary permeability. This leads to fluid extravasation into the interstitial space, resulting in relative hypovolemia. Altered metabolism. Increased metabolic demand and anaerobic metabolism contribute to elevated lactate levels. These changes affect fluid resuscitation management as follows. Fluid type. Initial resuscitation typically involves isotonic crystalloids, e.g. normal saline or lactated Ringer solution, to restore intravascular volume. Volume goals. Fluid administration aims to increase preload and improve cardiac output. The response to fluid resuscitation is monitored through vital signs, urine output, and central venous pressure (CVP). Caution with over-resuscitation. Due to increased capillary permeability, aggressive fluid resuscitation can lead to pulmonary edema. Discuss the implications of using inotropic support in pediatric patients with shock. Under what circumstances should inotropes be initiated, and what are the potential complications of their use? Answer: inotropic support is often indicated in pediatric patients with shock when there is inadequate perfusion despite fluid resuscitation. Key considerations include indications for inotropic support. Initiate inotropes when the patient presents with persistent hypertension despite adequate fluid resuscitation. There is evidence of poor perfusion, e.g., altered mental status, delayed capillary refill. Cardiac output is insufficient due to conditions such as cardiogenic shock. Common inotropes. Agents like dopamine, epinephrine, or norepinephrine are frequently used to enhance myocardial contractility and improve blood pressure. Potential complications. Arrhythmias. Increased risk of tachyarrhythmias due to heightened myocardial excitability. Ischemia. Inotropic agents can increase myocardial oxygen demand, potentially leading to ischemia, particularly in patients with underlying heart disease. Vasoconstriction. In some cases, agents like norepinephrine can lead to peripheral vasoconstriction, affecting distal circulation. In a case of pediatric cardiac arrest, what are the critical signs that a clinician should recognize as indicators of impending arrest? Discuss at least 3 signs and their implications. Answer: 3 critical signs of impending cardiac arrest in pediatric patients include hypoxia. A low level of oxygen in the blood can lead to cellular dysfunction and eventual cardiac arrest. Clinicians should monitor oxygen saturation levels and be vigilant for symptoms such as cyanosis or altered mental status. Bradycardia. A heart rate below 60 beats per minute in infants and children is concerning. It often signifies a compromised cardiovascular system and can lead to arrest if not addressed promptly. The underlying causes should be investigated, and appropriate interventions such as administering oxygen or performing chest compressions may be required. Altered consciousness. Changes in consciousness, such as lethargy or unresponsiveness, can indicate inadequate cerebral perfusion. This can result from hypoxia or bradycardia. Continuous monitoring and assessment of neurological status are crucial, and interventions should be initiated immediately to restore adequate blood flow. Understanding these signs is critical for timely intervention and improving outcomes in pediatric cardiac arrest situations. Describe the technique for high-quality pediatric CPR and explain the rationale for the recommended compression-to-ventilation ratio for both 1 rescuer and 2 rescuer scenarios. Answer: high-quality pediatric CPR involves several key elements. Compression technique. Compressions should be performed at a depth of approximately 1.5 inches, 4 centimeters for infants and 2 inches, 5 centimeters for children, with a rate of 100-120 compressions per minute. Allow full chest recoil after each compression to facilitate venous return. Compression to ventilation ratio. The American Heart Association (AHA) recommends a compression to ventilation ratio of 30, 2 for 1 rescuer CPR and 15, 2 for 2 rescuer CPR. The rationale behind this difference is that with 2 rescuers, the second rescuer can more effectively manage ventilation while the first rescuer maintains continuous compressions. This optimized ratio enhances circulation and oxygenation during CPR, ultimately improving the chances of successful resuscitation. Following these guidelines is critical in maximizing the effectiveness of CPR in pediatric patients, ensuring adequate perfusion and oxygenation until advanced care is available. A 3-year-old child presents with ventricular fibrillation after near-drowning incident. Discuss the steps you would take for defibrillation and the appropriate energy levels to use. Answer: in the case of a 3-year-old child in ventricular fibrillation, the following steps should be taken for defibrillation. Preparation. Ensure the child is in a safe environment and other rescuers are ready to assist. Check responsiveness and call for emergency assistance if not already done. Defibrillator use. Use an automated external defibrillator, if available. Ensure the child is on a firm surface to allow for effective defibrillation. Pad placement. Place pediatric pads according to the manufacturer's instructions, typically in an anterior-posterior position, 1 pad on the front of the chest and 1 on the back. Energy levels. For a child experience deliver a shock at 2 for GG using the defibrillator. If the first shock does not restore a perfusing rhythm, additional shocks may be given, and advanced resuscitation measures should be initiated. Post-shock management. After defibrillation, immediately resume CPR for 2 minutes before reassessing the heart rhythm and pulse. The prompt and appropriate use of defibrillation is crucial for re-establishing a normal heart rhythm and improving the likelihood of a successful outcome in pediatric cardiac arrest scenarios. Mr. Thompson is a pediatric emergency nurse witnessing a code blue involving a 5-year-old with bradycardia and altered consciousness. As the lead rescuer, what immediate actions should Mr. Thompson take in this scenario to address the child's condition? Answer: in this scenario, Mr. Thompson should take the following immediate actions. Assess the child. Quickly assess the child's airway, breathing, and circulation. Establish the child's responsiveness and check vital signs, particularly heart rate and oxygen saturation. Initiate CPR if necessary. If the heart rate is below 60 beats per minute and the child is unresponsive, Mr. Thompson should initiate CPR immediately. Follow the appropriate compression to ventilation ratio and ensure high-quality compressions. Administer oxygen. Provide supplemental oxygen to improve oxygenation, particularly if the child is exhibiting signs of hypoxia. Call for help. Ensure that emergency assistance is summoned if not already done. Engage the code team to prepare for potential advanced interventions. Consider medications. Given the bradycardia and altered mental status, Mr. Thompson may consider administering atropine as per the Pediatric Advanced Life Support (PALS) guidelines to increase heart rate if IV access is available. Following these steps is critical for addressing the child's condition effectively and promptly, as timely interventions can significantly impact outcomes in pediatric emergencies. Discuss the indications for synchronized cardioversion in pediatric patients and describe the procedure steps. Answer: synchronized cardioversion is indicated in pediatric patients experiencing tachyarrhythmias that are causing hemodynamic instability. Specific indications include supraventricular tachycardia (SVT), when the child exhibits signs of poor perfusion such as altered mental status, hypotension, or chest pain; ventricular tachycardia (VT), in cases of VT with a pulse where the child is symptomatic. Procedure steps: prepare the patient, ensure the child is in a safe position and monitor vital signs. Obtain IV access and place ECG leads to confirm the rhythm. Apply pads. Use appropriate sized pads and place them in the anterior-posterior position. Select energy dose. For synchronized cardioversion, select an initial energy dose typically between 0.5 mg. If the first shock is unsuccessful, increase the dose to 10 mg. Synchronize the defibrillator. Ensure the defibrillator is in sync mode to avoid delivering shocks during the refractory period of the cardiac cycle. Deliver shock. Clear the area and deliver the shock. Immediately follow with CPR if the child becomes unresponsive or if the rhythm does not convert. Identify the importance of continuous CPR in intubated pediatric patients and explain how this differs from traditional CPR techniques. Answer: continuous CPR in intubated pediatric patients is crucial because it ensures consistent circulation and oxygenation during resuscitation efforts. This approach differs from traditional CPR techniques in the following ways. Airway management. In intubated patients, the airway is secured, allowing for ventilatory support without the need for rescue breaths during continuous chest compressions. Compression-only technique. Continuous CPR focuses on high-quality chest compressions without interruptions for ventilation. The goal is to maintain blood flow and perfusion to vital organs until advanced care is available. Ventilation support. While compressions are ongoing, mechanical ventilation can be used to provide oxygenation, allowing for a more controlled and effective management of the airway. Use of capnography. Monitoring exhaled carbon dioxide echo can help assess the effectiveness of CPR. A return of echo levels may indicate improved circulation and guide further resuscitation efforts. Implementing continuous CPR in intubated pediatric patients enhances the likelihood of successful resuscitation by maximizing cardiac output and optimizing oxygen delivery to critical tissues. Describe the considerations for administering sodium bicarbonate during pediatric cardiac arrest and the specific indications for its use. Answer: sodium bicarbonate is sometimes considered in pediatric cardiac arrest, particularly in specific situations where metabolic acidosis is suspected. Considerations for use. Indications: severe metabolic acidosis pH 7.1 that is not responding to other treatments, particularly in cases of prolonged arrest or after successful resuscitation when acidosis may persist. Known or suspected hyperkalemia, as bicarbonate can temporarily shift potassium intracellularly. Dosing: the typical dose of sodium bicarbonate in pediatric patients is 1 mg/kg with subsequent doses based on the patient's pH levels and clinical response. Timing: sodium bicarbonate should not be administered as a first-line treatment during cardiac arrest. Its use is generally reserved for situations where other resuscitation efforts have not been successful or when laboratory values suggest severe acidosis or hyperkalemia. Monitoring: continuous monitoring of arterial blood gas levels is essential to assess the effectiveness of sodium bicarbonate administration and to prevent overshooting alkalosis. Using sodium bicarbonate judiciously and understanding its role in the context of advanced pediatric life support can help optimize the chances of successful resuscitation and recovery in critically ill children. Outline the steps in managing an allergic reaction in a pediatric patient, including the administration of epinephrine. Answer: The management of an allergic reaction in a pediatric patient involves the following steps. Assess the patient, evaluate the severity of the allergic reaction, look for signs such as urticaria, swelling, wheezing, or signs of shock, call for help, activate emergency services if the reaction is severe or life-threatening, position the child. If the child is having difficulty breathing, position them comfortably, typically sitting up to ease respiratory distress. Administer epinephrine. If anaphylaxis is suspected, administer epinephrine promptly. The dose is 0.1 mg up to a maximum of 0.3 mg intramuscularly, preferably in the mid-anterolateral thigh. This can be repeated every 5 minutes as needed. Provide supportive care. Monitor vital signs and provide supplemental oxygen if the child exhibits respiratory distress. Post-administration monitoring. Observe the child for any adverse reactions to the epinephrine and provide additional care as needed, including intravenous fluids if signs of shock persist. In the context of pediatric trauma management, what are the key components of the primary assessment and how do they guide further treatment? Answer. The primary assessment in pediatric trauma management follows the ABCD approach. Airway. Assess and secure the airway. Look for any obstructions and ensure adequate ventilation. The presence of stridor, snoring, or gurgling indicates a compromised airway that needs immediate intervention. B. Breathing. Evaluate the quality of breathing. Check for adequate chest rise and fall, breath sounds, and signs of respiratory distress. Supplemental oxygen should be provided as necessary. C. Circulation. Assess circulation by checking for pulses, skin color, and capillary refill time. Monitor for signs of shock, such as hypotension, altered mental status, or prolonged capillary refill. Initiate IV access for fluid resuscitation if necessary. D. Disability. Perform a quick neurological assessment using the AVPU scale, alert, verbal response, pain response, unresponsive, to evaluate the child's level of consciousness. Look for signs of head injury or altered mental status. The exposure environment. Expose the patient to assess for any hidden injuries while ensuring the child's warmth to prevent hypothermia. A 7-year-old boy presents with respiratory distress and wheezing after exposure to a known allergen. What are the initial steps in managing this patient, and what is the appropriate medication and dosing for bronchodilator therapy? Answer. In managing a 7-year-old with respiratory distress and wheezing due to an allergic reaction, assess the severity, evaluate the child's respiratory effort, auscultate breath sounds, and check for signs of hypoxia, cyanosis, altered mental status. Positioning. Place the child in a comfortable position, usually sitting up, to ease breathing. Supplemental oxygen. Administer supplemental oxygen to maintain oxygen saturation levels above 94%. Bronchodilator therapy. Administer short-acting beta-agonist, such as albuterol. The appropriate dose for a child is typically 2.5 mg via nebulizer every 20 minutes for up to 3 doses, or 90180 ag, 2 puffs via meter-dose inhaler, and DI as needed. Reassess. Continuously monitor the child's response to therapy, looking for improvement in wheezing and respiratory effort. Following these steps can significantly improve airway patency and oxygenation, addressing the acute respiratory distress effectively. A 3-year-old child is brought into the emergency department with a severe cough, difficulty breathing, and audible stridor at rest. On examination, the child has nasal flaring, retractions, and a barking cough. What is the most likely diagnosis and what is the immediate treatment protocol? Answer. The most likely diagnosis is croup laryngotracheobronchitis, which is an upper airway emergency caused by viral infection leading to subglottic swelling. Key treatment protocols: mild croup, supportive care, hydration, humidified air. Moderate to severe croup, nebulized epinephrine. This is the primary treatment for children with stridor at rest. It reduces airway swelling and provides rapid relief of symptoms. Corticosteroids. Dexamethasone or prednisolone to reduce inflammation, 0.15 0 points AG or intramuscularly. Oxygen. Administer oxygen if the child shows signs of hypoxemia, SPO 92%. Guideline reference. The treatment of croup follows the American Heart Association (AHA) and Pediatric Advanced Life Support (PALS) recommendations for managing upper airway emergencies. Which clinical signs would indicate that a pediatric patient with asthma is progressing from respiratory distress to respiratory failure? Answer. Signs of progression from respiratory distress to respiratory failure in an asthmatic child include increased work of breathing, tachypnea, nasal flaring, and use of accessory muscles may worsen. Exhaustion due to increased effort in breathing, hyperventilation, reduced air movement indicating that the child is tiring. Altered mental status, agitation progressing to lethargy or a decreased level of consciousness. Cyanosis, peripheral or central cyanosis indicating inadequate oxygenation, hypocarbia, rising CO levels, POCA 45 mm Hg, suggesting that the child is unable to maintain adequate ventilation. Immediate intervention with bronchodilators, nebulized albuterol, corticosteroids, and possibly non-invasive ventilation or mechanical ventilation is crucial to prevent further deterioration. Emma, a 6-year-old girl, is admitted to the pediatric ICU with severe respiratory distress. She has a history of reactive airway disease and presence with wheezing tachypnea, 50 breaths per minute, and use of accessory muscles. Despite receiving albuterol nebulization in the emergency room, she continues to show signs of respiratory distress. Her SPO is 90% on, a non-rebreather mask, and she has a weak cough. What should be the next step in managing Emma's condition? Answer: Emma is presenting with severe asthma exacerbation, and despite bronchodilator therapy, she continues to deteriorate. The next steps in her management should include continuous nebulized bronchodilators, albuterol, and possibly adding ipratropium bromide anticholinergic agent, systemic corticosteroids. If not already administered, start with intravenous methylprednisolone. Non-invasive ventilation, consider CPAP or BiPAP to decrease the work of breathing and improve oxygenation. Magnesium sulfate can be administered intravenously for severe exacerbations as it has bronchodilatory effects. Monitoring and escalation. If she continues to deteriorate, intubation and mechanical ventilation should be considered. Guideline reference. This management follows the PALS guidelines for treating severe respiratory distress due to asthma or reactive airway disease. A 5-year-old child presents with high fever, drooling, and sitting in the tripod position. On examination, you notice stridor and respiratory distress. What is the most likely diagnosis and what is the first priority in managing this condition? Answer: the most likely diagnosis is epiglottitis, a life-threatening bacterial infection causing inflammation and swelling of the epiglottis, leading to airway obstruction. First priority in management: do not attempt throat examination or anything that may agitate the child, as it could lead to complete airway obstruction. Immediate airway management is crucial. The child should be transferred to an operating room or ICU for controlled intubation by an experienced clinician. Administer humidified oxygen to maintain oxygen saturation. IV antibiotics should be started after securing the airway, ceftriaxone or cefotaxime. Guideline reference. The management of epiglottitis as per PALS guidelines emphasizes rapid recognition and securing the airway as the priority. What is the role of CPAP, continuous positive airway pressure, in the management of pediatric patients with respiratory distress due to lower airway disease? Answer: CPAP helps maintain positive airway pressure during both inspiration and expiration, which prevents airway collapse and improves oxygenation and ventilation. In pediatric patients with lower airway diseases such as bronchiolitis or asthma, CPAP reduces the work of breathing by maintaining airway patency. It helps in recruiting alveoli, reducing atelectasis, and improving gas exchange. CPAP can be particularly beneficial for children with bronchiolitis or severe asthma exacerbations where increased airway resistance and hyperinflation are present. CPAP is non-invasive and is usually attempted before considering mechanical ventilation, especially in cases of moderate to severe respiratory distress. Guideline reference. The use of CPAP is endorsed in PALS protocols for non-invasive management of respiratory distress before resorting to more invasive methods. Mr. Thompson's 4-year-old son, Jason, is brought to the hospital with a cough, fever, and difficulty breathing. Jason has a history of asthma but was not using his inhaler regularly. Upon examination, Jason's breathing rate is 45 breaths per minute with significant wheezing and retractions. His SPO is 89% on room air. What should Mr. Thompson expect in terms of immediate and ongoing management for Jason? Answer: Jason's presentation suggests a severe asthma exacerbation. Immediate and ongoing management should include administering oxygen to maintain SPO 92%, nebulized bronchodilators, albuterol in frequent or continuous doses, systemic corticosteroids to reduce airway inflammation. If there is minimal response to the above, consider non-invasive ventilation. BiPAP. Magnesium sulfate can be used intravenously in cases of severe exacerbation. Jason will require close monitoring in a high-dependency unit or ICU for further respiratory support if necessary. Mr. Thompson should ensure strict adherence to asthma action plans and regular follow-ups to prevent future exacerbations. Guideline reference. This follows the PALS guidelines on managing respiratory distress and failure in children with a history of asthma. What are the indications for using mechanical ventilation in a pediatric patient with respiratory failure due to pneumonia? Answer: indications for mechanical ventilation in children with pneumonia include respiratory failure, when non-invasive methods, CABAPAP, are insufficient and the child cannot maintain adequate oxygenation or ventilation, SPO 50 mm Hg, indicating that the child is unable to clear co-effectively, altered mental status, indicating hypoxia or co-retention, severe work of breathing, when the child is too fatigued to continue breathing efforts effectively. Mechanical ventilation helps control ventilation, oxygenation, and co-removal, allowing the lungs to rest while underlying conditions are treated. Guideline reference: the PALS algorithm for respiratory failure and pneumonia prioritizes early recognition of mechanical ventilation if the child's respiratory status worsens. A child is diagnosed with central respiratory depression due to a seizure. How does this condition differ from other forms of respiratory failure, and what is the immediate intervention? Answer: central respiratory depression is caused by an impairment in the brain's respiratory centers, leading to reduced respiratory effort. This contrasts with other types of respiratory failure where airway or lung pathology, e.g., obstruction infection, directly impairs breathing. Immediate intervention includes airway protection, ensure the airway remains patent, ventilatory support, provide oxygen, and consider non-invasive ventilation or intubation depending on the severity of the respiratory failure. Treating the underlying cause, in this case, stopping the seizure with benzodiazepines or other anticonvulsants and addressing the cause of central respiratory depression. Guideline reference: PALS guidelines emphasize immediate airway and breathing support in children with central respiratory failure, prioritizing treatment of the underlying cause. Mrs. Lee brings her 2-year-old son, David, to the emergency room with sudden onset respiratory distress after playing outside. He has a history of seasonal allergies and asthma. Upon arrival, David is wheezing, has a prolonged expiratory phase, and is visibly anxious. His SPO is 88% on room air. What initial management steps should be taken to address David's condition? Answer: David's symptoms suggest an asthma exacerbation likely triggered by outdoor allergens. Initial management should include positioning. Place David in an upright position to maximize lung expansion. Oxygen supplementation. Administer oxygen to maintain SPO 92%. Nebulized bronchodilator. Administer albuterol immediately for rapid bronchodilation. Assess for response. Evaluate the improvement in symptoms and oxygen saturation post-nebulization. Consider systemic corticosteroids. Administer if symptoms persist despite bronchodilator therapy. Ongoing monitoring is crucial, and further intervention may include adding ipratropium bromide or using non-invasive ventilation if David continues to show signs of respiratory distress. Guideline reference: PALS protocols dictate that initial management of severe asthma exacerbations should focus on quick stabilization and symptom relief. Explain the significance of monitoring vital signs and clinical status in a pediatric patient experiencing respiratory failure. What parameters should be closely observed? Answer: monitoring vital signs and clinical status in a child with respiratory failure is critical for detecting deterioration. Early identification of worsening respiratory status allows for timely intervention, guiding treatment decisions. Changes in vital signs can dictate the need for escalated care, such as mechanical ventilation. Assessing effectiveness of interventions. Monitoring allows healthcare providers to evaluate the effectiveness of treatments being administered. Parameters to observe include respiratory rate. Increased rates may indicate distress. A decreased rate may suggest fatigue or failure. Heart rate. Tachycardia may signal hypoxia or distress, while bradycardia may indicate severe respiratory failure. Oxygen saturation, SPO, should be maintained 92% in most scenarios. Frequent checks are essential. Blood pressure. To assess perfusion status, a hypotension can indicate shock or severe respiratory distress. Level of consciousness. Changes can indicate worsening hypoxia or co-retention. Guideline reference: PALS emphasizes continuous monitoring and reassessment of vital signs in children with respiratory failure to ensure timely and appropriate interventions.